Quickly, we will move on to the next session. I would like to invite Dr. Nandini and Dr. Nishan Pandey from Dr. Jayashekharan Hospital for the clinical case discussion on carcinoma thyroid. I would like to invite Professor Dr. Dayananda BABU sir, Professor Emeritus Surgery from Sri Gokulam Medical College, Trivandrum, Professor Dr. JUDE ANSELM SHYRAS sir, Professor and HOD ENT from Kanyakumari Government Medical College, Dr. RAJKUMAR sir, Associate Professor from Tirunelveli Government Medical College to chair this session. Thank you.
Good afternoon, sir. We are going to present a case on a CA thyroid.
Introduce yourself. From which hospital?
From Jayashekharan Hospital, sir.
Okay. Go ahead.
So we had a patient of 47-year-old female, housewife by occupation, present with the chief complaints of swelling in front of the neck since 1 year and swelling in the left side of the neck since 4 months. History of presenting illness. Patient initially noticed a swelling in front of the neck 1 year ago, which was insidious in onset, initially of size 1 into 1 centimeter and gradually progressed to the current size of 6 into 5 centimeter, which was associated with another swelling which she noticed in the left side of the neck 4 months back, which was initially in small in size of 1 into 1 centimeter and rapidly progressed to the present size of 5 into 4 centimeter. She had a history of undocumented weight loss since 1 year as noticed by the loosening of the clothes. There was no complaint of pain in the swelling, no complaints of change in the voice or difficulty in swallowing or breathing difficulty in lying down position. There was no history of fever, evening rise of temperature, no history of any bone pain or any other swelling in the body, no history suggestive of any hypo or hypothyroidism. Past history, there is no history, patient has no history of hypertension, diabetes or bronchial asthma, ischemic heart disease, hypo or hypothyroidism, no history of radiation exposure in the childhood. Family history wise, there is no similar history of cancer related thyroid cancer in the family. Personal history, she consumed mixed diet. Appetite is good, however patient has undocumented weight loss since 1 year. There was no history of sleep disturbances. Her bowel and bladder habits are normal and there was no addictions. Menstrual history, she attained menarche at 14 years of age, normal 28 cycles with the normal flow. For the past 3 months, she is having irregular cycles once in 2 to 3 months. Flow is normal. Obstetric history, she is P2L2, first childbirth at 20 years of age and second childbirth at 23rd year of age. So summary, 47-year-old female with no comorbidities with chief complaint of swelling in front of the neck since 1 year and swelling in the left side of the neck since 4 months with no history suggestive of compressive symptoms, no history of, there is history of documented weight loss since 1 year and no history suggestive of hyper or hyperthyroidism. So on the basis of history, my probable diagnosis will be, sir, CA.
No. This is clinical examination only. History.
History, sir.
Summary of your examination. What is the, you said loss of weight. How much weight she has lost?
Sir, we don't have any documentation, but as per patient history, she told that now she is having some loosening of the clothes.
So, do you expect loss of weight in all the carcinoma thyroid?
No, sir.
So, what is the, my question is whether she is having associated toxicity or not?
Basically, sir, if there is a history of, if there is a malignant transformation of the thyroid, there will be Not much associated with the weight loss, but if it is going for the hyperthyroidism, sir, it can associate it with
So,
the weight loss.
whether any toxic symptoms are there or not.
As per history, sir, no toxic symptom except from.
Toxic symptom.
So, second, what are the familial conditions associated with goiter?
Endemic goiter is common.
Familial syndromes associated with carcinoma thyroid.
Men syndromes,
Men is
Men, 2A.
men which one?
2A and B. Sir.
2A and B. Any other?
Gardner syndrome, sir.
Gardner. Any other?
Cowden syndrome.
Cowden syndrome.
What is Cowden syndrome?
Along with differentiated thyroid carcinoma and breast carcinoma along with hematomas. Sir.
And endometrial also.
Endometrial.
What is Carney complex?
Carney complex is also, sir, there will be there will be myxomas of the breast myxomas,
Gastric carcinoma.
Cutaneous and cardiac myxomas,
cardiac myxomas, breast myxomas, and cutaneous.
not breasts. What is McEwen-Albert?
Sebaceous carcinomas.
No, it is polycystotic fibrous
multiple
dysplasia
chondromas.
associated with thyroid malignancy. So many syndromes are there. Question is whether there is any family history of malignancy.
No, sir, no,
No, sir.
family history.
Any family history of the first degree relatives having goiter or tumor.
No, sir, no significant
sir.
Those
history.
things you should specify. And radiotherapy you have mentioned. For what? In the history. Why radiotherapy?
Sir, it will.
Papillary carcinoma is in history of any radiation in the childhood can progress into a papillary carcinoma.
What
What are the
radiation?
conditions?
For lymphoma and
Lymphoma,
tonsils,
tonsil
and adenoids.
adenoids.
What is ionizing radiation?
This CT scans and X-ray.
No, not CT.
and nuclear disaster.
Where? What is the example?
Chernobyl.
Chernobyl disaster. Especially less than 10 only. It's less than 10.
It's okay.
So,
This radiation, when does it cause cancer, malignancy?
It can take around 10 years to develop, sir.
At least 5 to 10 years, it can even be there in later days. That's why we are asking the history of radiation
In the
exposure in the childhood. Okay. With this history, you told I'm going to give a provisional diagnosis of a cancer or a malignancy.
Malignancy.
What made you think so?
Sir,
The second swelling is rapidly progressed, sir. From smaller size, it does rapidly
Within
progress
the-
without any pain and
Okay, you told that is in the left side of the neck,
Yes,
the
sir.
second swelling.
Within
What is
4
that second swelling actually?
it's a lymph node, sir.
Lymph node.
Yes, sir.
It has been growing there for the past 4 months.
4 months,
Yes.
yes, sir.
There is no change in size of the original swelling, or it's only progressing slowly.
Progressing slowly. I mean,
One
the
year,
lymph node-
sir, 1 year.
1 year
okay,
swelling.
1 year.
So, what are the changes you expect for a benign swelling to getting converted to malignancy?
Sudden increase in the size, sir.
Yes, but it is only a lymph node swelling. That is you're not about the
Main
main
swelling.
major. Okay, then
Any compressive disorder, sir, either change in voice because of the involvement of the recurrent laryngeal nerve.
nerve involvement, sir.
Nerve
Voice
involvement.
change.
no other history is positive to say that it
It
is
is
a
a
malignant, except there is a lateral
Lateral
swelling
swelling.
which is rapidly
Rapidly.
increasing in
Yes,
size. Okay, right.
So, could you please explain your history of presenting illness? Why you are asking those particular questions? Go back to your presenting illness. Okay, negative histories.
Pain,
So, weight loss since 1 year, and the
Yes, sir.
initial swelling also from since 1
Yes,
year.
sir.
Yes,
So,
sir.
from the start of the swelling itself, the patient is having weight loss.
Yes,
Yes,
sir.
sir.
And pain, it can be due to the nerve infiltration or else the tumor that is having hemorrhage into the swelling.
Suppose if you have a pain in the swelling, what do you think?
Hemorrhage into
Hemorrhage.
the gland or nerve infiltration.
So, could it be any other swelling apart from thyroid?
Painful thyroiditis.
Hashimoto.
Decurrent. Decurrent thyroiditis.
thyroiditis.
Okay, what about your third point, change in voice? Why you are asking about those questions?
Because if there is a malignant transformation of the thyroid swelling, it can involve the recurrent laryngeal nerve. It will cause the change in the voice, sir. Either it can be I mean, hoarseness of the voice can be there, sir.
And also in hypothyroid patients, hot potato voice due to
Hot
the
potato
edema.
voice.
I mean, sorry, sir.
Potato
hoarseness.
voice.
So where will you get
What
a
is
hot
the
potato?
cause in hypothyroidism?
Edema.
What is the cause for hoarseness in hypothyroidism?
Edema of the larynx.
Edema of the larynx. It is edema of the larynx. Right.
When will you get hot potato voice?
Quincy.
We are
Peritons.
talking about thyroid. Anything with the thyroid?
Lingual thyroids.
Ling-
So where will you get fever and rise of temperatures?
If we are suspecting this thyroiditis or even some inflammatory cause of the abscess.
Since there is a late neck swelling also and tuberculosis is common, I wanted to rule out that also, sir.
Tuberculosis, sir.
So,
Lymphomas?
lymphomas is a B symptoms of
B symptoms.
Okay, next.
So fever is a B symptom. What is the B symptoms of lymphoma?
night sweats, fever and
What night sweats?
trends.
No, that's very specific words are used.
Drenching night sweats.
Quenching means
Completely wetness.
you need to
Yes,
change the
clothes.
cloth. The quenching,
Quenching.
then what kind of fever?
No.
What kind of fever you are going to get in tuberculosis?
Evening rise of the fever,
Is
sir.
that is you are going to expect in a lymphoma?
Yes.
Night fever will. I don't know,
What is
sir.
Pellebstein fever?
Perlips. By
So how much weight loss?
more than
Of the body weight within the 6
Same
months,
B
sir.
symptom. This is the criteria. Only then you are going to call it a just fever is not a B symptom.
So from your history, I can understand the entire symptom starts within 1 year.
yes.
Yes, sir.
So, but you are talking about malignant transformation of some other pathology, right? Your wordings were like that only. So, could it be a, from the start itself, could it be a malignant swelling of the thyroid?
Maybe, sir, because 1 year history is there, so it can be from the
More
starting.
worried
only.
about the second swelling alone. So she was not mainly worried about the main central neck swelling.
She may not be worried, but you should be
Yes,
You are
sir.
worrying.
1 year.
You are also worrying.
It can be, sir, malignant from the starting only because the history is very short. It's 1 year only, sir. It's not from like 4 or 5 years.
Okay.
No,
I think go to clinical examination. That is.
clinical examination.
Not much here.
Voice off.
Patient
Anything significant?
You said there is loss of weight, the clothes are loose. Now you have written well built.
nourishment is poor.
Well built.
So it cannot be when once the patient is losing weight.
She has cervical lymphadenopathy, which will be discussed later. And vital pulse rate is 74 per minute, measured in right radial artery. It's a high volume and regular rhythm, no specific character. Blood pressure is 130/80 mmHg, measured in right brachial artery by auscultatory method. And
Measured by? How did you measure the PR?
Auscultatory method, Spigmomab.
You auscultated.
Yes.
Pulse rate, how did you measure?
Well,
No, you have put as a PR 74 minutes measured. Means
I mean, counted in right radial arteries.
Trainer setting position.
high volume. What does it mean?
Show that high volume you have written. Just what is high volume?
Normal work.
Can you get a high volume in thyroid?
Hyperthyroid states.
Hyperthyroidic state, sir.
That's why I was asking whether
Because they are
patient.
pulling us to hypothyroidism.
Yeah, because initially they said loss of
Loss of
weight,
weight.
and now they are saying high volume pulse. All those things are pointing to hyperthyroidism.
Local examination, patient examined well-lit room with adequate exposure and with due informed consent.
Local examination of the neck. Examination of the neck. Not, don't put just local examination.
Okay. Clinical picture of the patient.
Show the second picture. Where is the swelling? Second swelling. Just point.
This is the second.
Where is the main swelling?
This, sir.
Lower.
Lower
Yes,
is
sir.
the
Not visible actually. Show the previous picture. The
So
lower
here-
part.
yes, sir. This is the primary
That is
swelling, sir.
okay.
This
Okay.
is the
That
secondary.
is the okay. Right.
On inspection, a swelling of size 6 into 5 centimeter extending from the anterior borders of both sternocleidomastoid, superiorly extending below the prominence of thyroid cartilage and inferiorly 0.5 centimeter above the supraarch. The swelling moves with deglutition and lower border. Surface of this
Lower border is visible or not?
is a
Visible.
In this photo, due to
in this photo it is not visible, so actually it's
Clinically, lower border is visible or not?
visible, sir.
Visible. Lower border of which swelling is visible?
The midline swelling, sir.
The lower
Lower
swelling.
swelling.
Visible.
Yes, sir.
Okay.
Surface of the swelling appears smooth with well-defined margins. Pembertus sign is negative and no prominent veins were noted. On
That's all you are seeing. Inspection. There is two swelling. One is on the upper part, little
Yes.
lateral. Anything else you specifically look for that. You said it is swelling is moves. Both the swellings are moving with deglutition.
no, sir.
No, sir.
Above one is not moving with deglutition. That will be.
No, you are not mentioning anything about this. No, inspection means you have to talk about all those things. You are going to separate each swelling separately. No.
Neck node
Inspection, you are going for the examination of the neck. The first swelling, the second swelling, then you should go for that. Anything specifically you look for the second swelling because it's in the. It's not moving with deglutition. Is there a cough impulse? Is there?
No, sir. Laryngos, we have to. No cough impulse.
You have made up your mind that it is a lymph node swelling and you are going like that. So initially, it's always considered as a swelling and go as per protocol.
On palpation, there is no local rise in temperature. A diffusely enlarged swelling of size 6 cross 5 centimeter extending from the anterior border of both sternocleidomastoid, extending superiorly up to the thyroid prominence and inferiorly 0.5 centimeter above the suprasternal notch. The swelling is firm in consistency.
Always, please do not go and do this all these measurements. Do the swelling is in the thyroid region, involving both the lobe or not. 5 centimeter from here. That is what SHYRAS lower border is visible. We are not worried whether it is 5 centimeter visible, 1 centimeter visible. That is not necessary also for that. Swelling in the thyroid region, both the lobes visible, lower border is visible.
okay, sir.
The swelling is firm in consistency, no nodules and moves with deglutition. Lower border is palpable. Skin over the swelling is pinchable. There is no thrill present over the swelling.
Do
Trachea.
you want to pinch the skin? What is the purpose of doing pinching the skin? You have the habit of pinching others.
Skin involvement we have.
You said it is moving with deglutition. So when there will be the skin involved, will it move with deglutition? Postgraduate, do not do routine again and again. Do what is necessary, what is not necessary.
Okay. Trachea shifted to the right and left side carotid pulsation displays backwards and
Is a palpation finding or inspection? Trachea shifted to the right.
palpation.
Palpation findings
Palpation.
Inspection?
not visible.
You have not mentioned anything about that in the inspection.
Couldn't make out the
Couldn't make out,
trachea.
sir.
How did you palpate for the
Finger.
3-finger test. With
That name we know, but he is asking how you will do that. He is not asked the name.
with one finger on the, index finger on the both of the sternal ends of the clavicle, and with the middle finger we have to insunate the fingers on either side of the trachea, or trace the trachea and see the direction.
Here you are able to trace the trachea. The swelling is over the trachea or not? Swelling appears to be a
Appears to
diffuse
be
swelling over the trachea. Then how did you insultate it?
isthmus, everything is
Yes, sir.
How did you do that? Any other method to say it is in midline?
We ask patient to swallow and we can.
Nothing will see.
In such a situation, only auscultation. Because the swelling is covering the trachea there. You are not seeing, initially you said you are not seeing. Because there is swelling overlaying. So, I don't know how you are now telling it is not shifted.
It's shifted, sir.
To which side?
Right, sir.
Right side.
Yes.
But you are not seeing anything there. Okay. Swelling is covering. That's it.
Where do you get the sign? Trail sign, right side or left side? The swelling is shifted to the right side.
Right side, sir. Right side, sternocleidomastoid will be prominent, sir.
So you are not seen.
Couldn't.
So as sir has said, it's only by auscultation method or by radiological methods only you will be able to see that. So that is what important. Auscultation, you must see this breath sound is heard or heart sound is heard. Not coming here immediately saying no bruit. Okay.
Examination of the neck.
Carotid, where did you feel? Carotid.
Over the Chesignax tubercle, C6.
Where is it? C6.
C6 transverse process.
It is not. It is displaced.
Yes.
Yes, sir.
And you are feeling behind.
Yes, sir.
What is the inference?
It could be the carotid sheath is not infiltrated and the swelling is pushing the carotid.
No infiltration.
Absent, pulsations will be
pulses,
absent,
sir.
very sign.
The flow is there.
Yes, sir.
Flow will be there, sir, but that pulsation will not.
This swelling has the habit of pushing. This side is a pushed the trachea, that side it has pushed the.
Examination of the neck, swelling of side.
Now only examination neck comes. Previously,
It was the swelling, midline swelling. So this was for lymph node.
All examination of neck only.
I'll correct it, sir.
Which part of the neck you are examining now?
The lateral part, the
You
upper
just-
swelling, sir. Okay, sir.
Yeah. So you cannot just say that examination of the neck again. Thyroid is where?
In the midline, sir.
Thyroid
And
is
between-
in which part of the body?
Neck, sir.
Neck only. So another second neck cannot come. So
all has to put together, all inspection should be together.
Together.
okay, the second swelling you are described.
Upper swelling. Swelling of size 5 cross 3 centimeter at the junction of upper and middle third of the left sternocleidomastoid with smooth surface and well-defined margins. Cystic in consistency, non-tender with restricted mobility, and skin over the swelling is free. The swelling does not moves with deglutition, suggestive of enlarged level 2 and 3 nodes.
Why you are coming to conclusion at this stage? It is
Cystic swelling again. Cystic inconsistency, lymph node.
It was
Which lymph node will have a cystic inconsistency?
with metastasis.
You said that it is fixed. Something you said. This swelling is fixed. Second,
No, not fixed, sir, but restricted mobility.
what about the other swelling? First, you never mentioned.
That
about-
was not fixed, so that was mobile.
Did you see?
Yes,
Look
sir.
for it.
Yes, sir.
Yes, sir. Side
Which mobility you checked?
Side to side.
Side to side and also move with the
That-
default
Both
touch.
both direction, no fixity.
No, sir.
No, sir.
But this one is restricted.
Yes, sir.
What is Fontaine sign?
Sir, the
Side
to side movement of the swelling
So which tumor will have?
carotid body tumor
tumor,
and
sir.
vagus nerve schwannoma.
schwannomas.
What is that sign called?
Fontaine signs.
Right.
What are the other cystic swellings in this region?
Cystic high.
Why not you think about the cystic swelling?
Branchial cyst.
Branchial cyst.
That is also
Cycle.
mobility may be restricted there.
Dermoid.
Brachial.
This is the brilliantly transluminant cystic swelling there.
Cystic
Cystic
hygroma.
hygroma.
Hygroma. Any other cystic swelling?
Branchial cyst.
The the laryngosal, pharyngeal pouch, so many things are there.
Translumination.
So the cyst is swelling out of a node will be a cold abscess.
Yes, sir.
So you are thinking in terms of cold abscess. It is coming to the anterior border of the sternocleidomastoid.
That will produce loss of weight also. Isn't it?
Yes, sir.
A cold
Cold
abscess, tuberculosis will produce loss of weight with maybe ordinary normal thyroid or benign thyroid, possible. No, you have to be open-minded.
Yes, sir.
Don't be myopic.
It is known in a malignancy. You usually don't expect to be a cystic swelling.
Yes.
You may be right at the end, but in the presentation, you should not go with the towards that, and at this point with the cystic swelling, saying it is a node, that only give an impression that somebody has given the clue of the diagnosis, and you are saying that. Have an open mind, talk with that. You should check for a cough impulse in this case. Check whether there is a swelling is there. Cold abscess you should check. Branchial cyst you should look for that.
Any local rise of temperature
No, sir,
for
no
this?
local rise in temperature.
Right. So still could be cold abscess.
Okay, proceed.
Which carotid you pulsated?
Common count.
Sure.
Yes, sir.
Okay.
Systemic examination. Respiratory system, normal vesicular breath sounds heard. And cardiovascular system, no murmurs, S1, S2 heard. Per abdomen, no.
Why you
no
are
organ.
examining respiratory system?
Because of the tracheal deviation.
Yes,
wanted to see.
because of tracheal deviation. You are suspecting what?
Strider.
Strider.
Due to long stand.
So for strider you are examining respiratory system. If I am the person, I will say, if I am suspecting a carcinoma, maybe metastasis to the lungs. What is the commonest site of metastasis?
Lymph node metastasis.
Other, no, this system,
Blood-borne.
metastasis. Which system it will go?
Sir is asking from thyroid, where from the common sites of metastasis.
Lungs and bones.
Eh?
Lungs and bones.
Lungs and bones.
I see two-third will be to lung,
Lungs and
one-third to bone. That is the general statistics. So, you automatically you will examine the chest. I don't know the system examination is there or not. Surgery we always talk about chest, abdomen, metastasis in abdomen. Maybe liver, spleen, ascites, all those. We don't go to oral cavity normal like GI system for medical. That is a medical examination pattern. Right. And always you say S1, S2 normal. Cardiovascular, if it is of course hyperthyroid, you have to mention all those things. Right.
There is loss of weight. Anemia is there or not?
Anemia was not there.
You said ill nourished totally.
Poorly nourished.
Poorly nourished is not anemic. Okay. And anemia not producing murmur. What murmur you get in anemia?
End eyes.
You had a hyper volume, I mean, volume is also high.
High volume.
Okay. Always in the history, it correlates somewhere, sometimes. So one point, if somewhere you made a mistake, somewhere it will be always reflected.
Summary, a 47-year-old female with no known comorbidities.
For what you looked for the cranium?
Bony metastasis.
Bony metastasis.
Follicular
Pulsatile
carcinoma.
bony metastasis, sir.
What is pulsating?
So that
Underlying
the
osteolytic metastasis. So underlying brain pulsations.
dura is the pulsating. Dura will pulsate and we can feel that the secondary pulsation in the
Called the blowout metastasis. Blowout metastasis.
A 47-year-old female with no known comorbidities with chief complaints of swelling in front of the neck for 1 year and another rapidly enlarging swelling in the left side of the neck for 4 months with no history of any compressive symptoms or signs of hypo or hypothyroidism and positive history of undocumented weight loss since 1 year, and she has a diffusely enlarged thyroid swelling which is firm in consistency with palpable lower border and tracheal deviation towards the right with enlarged and fixed level 2 and 3 lymph nodes. Provisional. It,
She is not
It was
mentioning
more of-
matting. She is not mentioning matting.
no, sir.
Previous, just show.
It was.
Matted and fixed.
It restricted mobility was there, sir, and
No,
it
matting
was-
means what?
addition. I mean, two nodes are getting added to each
Adhere.
other.
In malignancy, what is the cause for matting?
Malignancy. I mean,
It is extranodal extension. It is extranodal extension. I don't know what you are feeling and what is your finding, but a carcinoma going to level 2 is quite unusual in thyroid. 3, 4, 5 all possible. Very, very rare to get a node level 2.
this case of carcinoma thyroid with secondaries in the neck.
Differential, open mind, differential diagnosis.
Due to the weight loss and high volume pulse.
It can be multinodular goiter.
Yeah, multinodular goiter
With
with,
Dominant thyroid.
Eh?
Dominant nodule of the thyroid.
and you have to give the diagnosis for the second one.
With the
Associated
Toxic.
cold abscess. Also.
Cold abscess, maybe matted lymph nodes possible. Which is the commonest node involved in tuberculosis? Cervical lymph node.
Posterior cervical.
Eh?
Posterior cervical nodes because of the spine.
Jugulogastric.
J-
The tonsillar node. That is involved or not in this one?
No,
No,
sir.
sir.
What is level 2 node?
Jugulogastric.
jugular digestive.
See, before
The
answering,
swelling is more.
maybe level 2, the jugulogastric with other nodes matted. Possibility is still there. Maybe your pathology report may be carcinoma, we don't know. But you should always think of differential and before committing and fixing to one diagnosis.
You said that diffuse thyroid. That is meant
Yes.
both the lobes are involved.
Yes, sir.
So, but you said only the node is on the left side.
Yes, sir. Left side alone, no.
So where is the malignancy you are expecting? Right side lobe or left side lobe?
Left side lobe.
Left side only, sir.
The consistency, you said consistency is firm or soft?
Firm, sir. The lymph
Node is
node
cystic.
No, no. So
Swelling
thy-
is firm.
the thyroid
Firm
Firm.
swelling.
form.
What is thyroid paradox?
Tensely cystic swelling. It is felt as hard nodule in papillary cast.
How you are going to proceed?
Sir, we'll do quadruple tester already history
Say
and
quadruple assessment.
assessment.
Yes.
History and examination complete. Now we'll proceed with the imaging. We'll do first ultrasound.
No, first is thyroid function test. This is not by me, the ATA guideline. You do a thyroid function. That is, that too, TSH. Do TSH, you get an idea where it is hyper or hypo. That is the first thing. If it is hyper, TSH is low, different line you will go. But if the TSH is normal or hypo, you go to the second line. The, what do you say?
Ultrasound imaging, sir.
Imagine. So that is the, so first is quadruple, second is the clinical exam. After that, go for TFT. And third is
FNAC.
ultrasound, not FNAC.
Third ultrasound followed by FNAC.
Ultrasound is a high resolution ultrasound. What is high resolution ultrasound?
7.5 megahertz.
To
16
16 megahertz.
megahertz.
So you do high resolution ultrasound. What finding you expect in malignancy?
Sir, first composition we'll see of the.
No, that is steroids. I am not asking steroids. What finding you will lead on to a suspicion of thyroid?
Increased vascularity loss. Solid and cystic.
Hypoechoic
Very
solid nodule.
Hypoechoic solid nodule, yes, sir.
If there is a hypoechoic solid nodule, you will suspect.
Malignancy.
Along with 4 things. What
Tall-
are they?
Taller, then wider. Sir.
1,
Then the
Microcalci-
microcalcifications,
2,
ill-defined margins,
irregular margin.
irregular margins,
And 4th,
Loss of halo.
disrupted rim calcification.
disrupted.
So microcalcification, disrupted rim calcification, taller than wide, irregular margin, you suspect malignancy. Then you go to THYROID. But this is the most important thing. If you don't know that, even a surgeon can look for a hypoechoic nodule, or whether it is if hyperechoic, it is benign only. You understand? So hypoechoic solid nodule, always one should suspect.
Yes, sir.
And so the remaining ultrasound findings and proceed. You wanted to tell about 5 features and all. Tell. You never asked.
Composition, echogenicity, size, and shape, margins,
and
echogenic foci.
calcification.
So based on that, how do you classify?
Sir, every score,
Scoring. So
Scoring
how do you
1 to
classify?
3.
How do you classify?
maximum score is 3, sir. So
No, it is TR 0, 1, 2, 3, 4. That is the
Benign. So,
thing up to 0. 0 is 1. 0 is TR
Score
1.
1.
TR 1 to 2 is benign. 3, 4, 3 is suspicious. 4 is highly suspicious. 5 is malignant. That is how the TR score holds. So something was done for this patient.
Sir said disrupted rim calcification. Suppose there is non-disrupted rim calcification?
it will not suggest, sir. I mean, only 2 score will give for the complete calcification of the periphery, sir. So we have to correlate with the other factors. Then we'll
So rim
decide.
calcification, is it more feature of benign or malignant?
benign.
Benign, sir. More feature of benign.
So when it is disrupted, you are going to suspect a malignancy.
Malignancy, sir.
2 need not be there. Hypoechoic plus one of these. 4 I have mentioned, one of these. So that need not be always there. Right.
Then we'll proceed with the FNAC, sir.
Guided FNAC.
Guided.
How FNAC is?
Procedure of the FNAC, sir. 23 gauze needle will take, sir, which will be 1.5 centimeter long. Then after fixing the, I mean, it is very large swelling, so we don't need any ultrasound, sir.
We'll prefer the solid component of
So your
using
concept is large no ultrasound, small ultrasound needed.
No, we preferably take the solid component using ultrasound.
So how do you know the solid component? Or not?
Ultrasound guided, sir.
Even for a large, I mean, the thyroid, especially even a cyst is swelling after aspiration, you may get a solid component. That you need to take. So it is preferably always ultrasound guided.
Why you are telling solid, large no need? From where did you get this idea? Because large nodule you suspect more chance for malignancy, especially more than 4 centimeter. And you are telling no need for FNAC. Why? Any reason? So which malignancy you diagnose by FNAC? 2 malignancies you diagnose by FNAC.
Anaplastic and lymphoma.
Papillary.
Huh?
Papillary and
And
lymphomas.
papillary and
Medullary.
medullary. Papillary. Anaplastic sometimes you cannot. May give spindle cells only. What will be the FNAC finding of medullary?
Medullary carcinoma.
Amyloid stoma.
Amyloid stroma and one more thing.
Sclerosing in
Cell balls. Cell balls, amyloid stroma. So 2 malignancies you can diagnose by
FNAC.
FNAC. So FNAC was done for your patient or not?
Is it showed Poorly differentiated cell, Bethesda 5 category, and either they gave.
What are the FNAC features?
In papillary carcinoma, sir. In aggressive type, there
No, in your case, what are the features described? What are the features described there?
Poorly differentiated cell with. Yes.
yes, sir. There was hobnail cells and tall cells, sir, present.
What is hobnail cell? What is hobnail cell?
You earlier said taller than wider, and you are now saying tall cell. And what is hobnail cell?
What is hobnail cell? You only said. So you should know what is hobnail.
Is it good or bad?
Bad, sir. It shows aggressive type of papillary.
It is aggressive, it will go to lungs. But describe hobnail cell.
Like.
It has got a cell with the nucleus apically situated, and the cell surface will be bulgy. That is a hobnail cell. Prognostically very bad. Papillary thyroid cancer, the bad type. So hobnail cell is there. And then any other?
What is this tall cell variant you said? What is the difference between taller than wider and tall cell variant?
Taller than wider, sir. It is a whole swelling we are talking about. It should be. In histology, we'll see tall cells, sir.
So tall cell variants.
Tall cell variant.
You talk like that. Tall cell variant. And one more cell variant is bad. What is that? Tall cell variant, columnar cell variant, hobnail variant, solid and sclerosing type. These are the 5 bad histology in papillary thyroid cancer.
What is the recent changes in the WHO classification on the solid cell variant? It belongs to whom? Originally, solid cell variant was in anaplastic carcinoma. Now, solid cell variant is brought into the papillary carcinoma. So, it is one of the variant of the papillary carcinoma. So, tall cell variant, hobnail cell, columnar cell, sclerosing. Then we have only solid cell variant is also now under the papillary carcinoma. What is indolent carcinoma? Lindsay tumor. Follicular cell variant of the papillary
carcinoma. It will have less than 1% minimal papillaries.
It's a non-invasive.
Non-invasive, sir. Follicular adenoma with the minimal papillary cells.
Is almost 100% curable. So that's then they do not typically call it as a malignant. It is brought in as a indolent carcinoma. What is dedifferentiated carcinoma?
Poorly differentiated carcinomas again after repeated, prolonged duration. After some time they de-differentiate into some other type, either papillary or anaplastic features also.
I think the genetic changes from completely differentiated, that is, what is differentiated thyroid cancer?
These 3.
What are they?
Papillary, follicular and Hürthle.
And?
Hürthle cell.
Hürthle cell. Then de-differentiation to poorly differentiated. From poorly differentiated again to anaplastic. This is how it goes. Actually I wanted to ask you about Bethesda. Before that you said the hobnail variant. What is the Bethesda grading of your FNAC?
Bethesda 5, sir. Highly suspicious of malignancy.
Malignant.
5 or 6? No, FNAC is done. So 5.
5, sir.
They put 5. You know Bethesda. Which Bethesda is the current one? Yes? Current one. The NIFT P is included in Bethesda. NIFT P. 2 columns are there. Okay, so you know the reports. How do you manage in this case?
What is the staging of your disease?
Sir, it is T3A. N1B.
T3?
T3A.
A. That means more than 4 centimeter.
Yes, sir.
T3A.
N1B. N1B, sir.
Lateral neck.
N1B.
Lateral.
Yeah, okay. N1B. Any other staging workup you do?
We'll do, again sir, we'll do CT chest to rule out the metastasis of the lungs, and we'll do, I think, an ultrasound.
Any need for a CT of the neck?
Since
Because no pressure effects, no hoarseness,
No need.
but you said the artery is pushed behind.
we wanted to see whether it is infiltrated into the
Whether it is surrounding or
fat
because
plane,
encasing. You only said that it is pushed behind.
pushing.
Yes, sir.
Perhaps that is the only, and maybe you know mediastinal nodes are there or not. In this case, the patient has got lateral nodes. Lateral nodes means you have to always rule out mediastinal nodes. So how do you know mediastinal nodes are? That is by CT.
CT only.
So when you take CT of the neck and CT of the chest.
What is the staging?
Stage, stage 4A, sir.
Stage?
Less than 55 years, so stage 2.
So age is the single most prognostic
Prognostic.
indicator in a
Thyroid.
differentiated carcinoma.
Different, yes, sir.
So never it goes for more than stage
2.
2.
2 in less than 55
55
both
years.
male and female. Okay.
Yes, sir.
Yes, sir.
That is why this is, if there is no metastasis, still it is stage 1 not.
Yes,
If
M1 is
metastasis
stage
is there, it will become stage 2 only. Because patient is less than, what is the age? of this?
47.
47.
Okay, stages?
Stage.
There is no confusion. What is the stage?
Stage 1, sir.
Stage
Still
one.
it is stage 1 only because patient is less than 55. This is the only human cancer where
Age
age is included in
Stage.
AJCC stage.
Stage.
AJCC.
Okay, suppose if it is a anaplastic carcinoma, what stage it goes?
Stage 4.
Stage 4.
4.
Even if it is a small tumor, T1, then in anaplastic carcinoma it goes for
Stage 4.
4.
So how do you proceed?
So we'll proceed with the total thyroidectomy with the lateral node dissection with the central node dissection.
No, lateral node dissection means what dissection?
2.
2 to 4 we are
Only 4? 2
plus
to 5.
2 to
2
5.
to 5.
But in this case, I don't know because the level 2 involvement is quite unusual. Therefore, I think maybe level 1 also you have to. So usually it is level 2 involvement is unusual. Therefore, better to remove level 1 also. Otherwise, 2 to 5 is enough. And plus, central you.
If involved.
Prophylaxically, if it is not even involved, sir, we'll remove the central node also.
Central compartment.
Yes, sir.
What is central compartment?
6.
No, what is it?
What is it? What are the
What is that?
components of it?
The boundaries. Boundaries. Boundaries.
From hyoid.
Yes. Boundaries of central compartment.
Superiorly it is
Hyoid to suprasternal.
Hyoid is superior.
Superior.
Lower.
suprasternal
Supras-
node.
Actually, it is innominate vein. Lateral.
Jugular.
The carotid arteries.
Carotid arteries.
That is the boundary of the central compartment. Usually, you don't go up to innominate. The boundary is innominate. You go to the sternal notch only. So, central compartment you have to do. Then, the
Later.
neck dissection you have to do. Followed by what is the further treatment? That is the most important.
So followed by after
Oh.
total thyroidectomy, we'll send patient for
Radioiodine uptake
radioiodine
study.
uptake.
Uptake. How much, what is the dose of cervical scan?
3.
No. One cervical one is enough. Whole body, maybe 3
to 4.
maybe little more maybe. And so there is residual thyroid there, you go for RRA,
Ablation.
remnant ablation. How much?
30. 30
Maybe 30 to 100.
Yes, sir.
30 to
Till
100.
100 we can give.
100. Up to 100 you can.
How do you prepare the patient for taking the uptake scan?
We'll keep her, we'll make her hypothyroid, will not give her thyroxine supplement, and we'll measure the TSH value. It should be above at least 30 picograms per DL. Recombinant, if patient is needs a scan immediately or soon, Then we can give a recombinant TSH injection. 2 injections can be given.
Dose?
0.9.
0.9 milligram. Right. So you give an injection and the TSH is above 30. Then what is that? And the precautions are asked.
Precaution will ask patient, will briefly describe about the procedure, sir. Because it is a radioisotope, though there will be the chances
Patient
of
should be
radiation.
isolated.
What isotope? What you are using?
131.
131, sir, for ablation.
No, before that, each patient should be on iodine-free diet
Iodine-free
for 2 weeks.
diet for 7 to 10 days, and it should not pregnancy and lactation or complete
2 years will-
contraindications.
That should be avoided. Then
Then we'll ask patient to have a separate room in the
that is barrier nursing. Barrier nursing.
Yes.
barrier nursing.
If
Competence.
whenever you give more than 30 millicurie, patient should be on barrier nursing. But diagnostic purposes, I think no need. But therapeutic, you always give more than 30, you need barrier nursing. Okay. And after that, so you have done remnant ablation. After that, what you do?
Then we'll check with the tumor marker, which is
No. One more whole body scan you should know after ablation to know whether there is any residual or metastasis. If metastasis is identified, that should be treated. Otherwise, what you do?
Follow up with the thyroglobulin
Thyroglobulin.
and TSH.
Thyroid suppression is a must for all.
Thyroxine supplement.
we have to replace the thyroid.
Thyroid suppression and follow.
Yes.
How do you suppress?
Thyroxine and of
What is the
dose of
dose?
175, 150 to 170.
Now, what is your criteria? Is it a dose you are going to calculate or something?
TSH,
TSH
depending on the
point-
high risk and low risk features. If
Very
it
good.
is
So
a
you
high
need to
risk,
divide the patient into low risk and high risk.
Yes.
high risk TSH should be maintained less than 0.1, and if it is a low risk feature, 0.2 to 5.
What is the high risk patient? That is the question.
A patient with extrathyroidal extension or lymph node size more than 3 centimeter with the gross
And extreme of age is also high risk.
T3, T4, T3, T4 lesion, definitely it will come. Any other?
Male sex is the male sex and extreme of ages, sir.
T3, T4. Then vascular invasion is there.
lymphovascular
Wildly invasive type is there. Any other?
lymph nodes of more than 3 centimeter size.
Lymph nodes.
Lymph nodes.
Metastasis. These are all. So your patient is high risk or low risk?
If lymph node size is
Only on the basis of lymph node high risk patient.
high risk.
T3.
Lymph node itself is a high risk.
Yes.
No, your patient is T3 only.
Yes, sir.
T3
What
and this one.
T3 and lymph node. both.
T3, T4 need. Okay, high risk.
Yes, sir.
So
Okay,
how much? How do you give TSH? Ultraxin.
Point.
Replacement dose is 100 micrograms, sir. But we have to give till suppression dose we have to give. We can give up to 150 microgram per day.
So your TSH level is 2.
We'll have to increase the dose, sir. Till the TSH comes down
Becomes
to less than
Aim is the
0.1.
TSH level should come, and it is not minimum 300.
Up to 300.
It comes, but sometimes you need to go little
Higher
more
also.
higher on that. So you said something thyroglobulin assay. What is the significance of that?
It's a marker for recurrence. So
Recurrence.
post-operatively we can assess the patient
So
during follow-up.
thyroglobulin is increasing, but your uptake scan, you do one more uptake scan after the ablation. That shows there is no node, no take up.
Have to search for metastasis.
How do you search?
It's called a tennis.
Tennis.
Thyroglobulin.
Elevation.
Ah.
No.
Thyroglobulin increase, negative iodine scan. Tennis. Thyroglobulin elevated, negative iodine scan.
So what you will do?
PET.
PET scan will do, sir.
PET scan. So why PET is effective? Why the iodine uptake is not there in that area?
For iodine uptake, that recurrent lesion should be the
No, it must be a sodium support.
sodium report, yes, sir.
So that is fault. But PDG do not need that. So that is why when we have the FDG, when you are giving, that will take up. So suppose you give a scan, will that produce a cold nodule or a hot nodule?
Cold nodule, sir.
Cold nodule.
Malignant will be cold nodule, sir.
Malignancy will produce a cold nodule. So what do you mean by cold nodule?
No, no, sir, it
So
will
if
produce
DJ
hot
pit,
nodules,
it
sir,
will
because of
be-
the activity, metabolic activity increase, sir. Hot nodule.
Thyroid it is cold.
Here it is depending on the surrounding tissue. The surroundings is not taking. Even the small minimum it is taking, it will be a hot nodule you are going to take.
Sir's question, FDG PET also is negative. Or how do you manage? But thyroglobulin is elevated. FDG PET negative. You have to treat with radioiodine, maybe 200 to 300 millicurie blindly. Because you don't find any source. But what is the normal thyroglobulin?
Less than
Normal thyroglobulin level, post-operatively, you said thyroglobulin follow-up, then you should know the normal thyroglobulin.
3 to 5 nanogram.
No, it should be, normally it is not,
It should not be detectable after surgery. sir.
not be
Not
detected.
traceable.
It should be less than 1. Even up to 2 you can. But if it is going beyond, it is suspicious. So along with that you should do one more thing, that is the anti-thyroglobulin antibodies. Thyroglobulin antibody should be done the same along with thyroglobulin. You do, and then what is the follow-up? Thyroglobulin alone you do,
And also clinical examination and ultrasound.
and ultrasound.
Ultrasound routine.
Ultrasound.
6 months you do thyroglobulin, and the maybe they want us to stop. So thyroglobulin and ultrasound.
Ultrasound, yes.
Every 6 months. Whole body no need. If only then the thyroglobulin is elevated, you do a whole body. So look for a metastatic deposit. Maybe sometimes even lung. I've seen patients with nodules in the lung, thyroglobulin elevated. But this is tennis is sometimes seen. So may not be detected in the radioiodine, may not be detected in CT scan, may not be sometimes detected in PET also. In that case, blindly you give radioiodine.
What percentage will be tennis positive? It is not just like, it is nearly 20% now. So more number of cases. So there is newer methods are coming. So what is the disadvantage of giving 200 millicurie, 300 millicurie?
Too much of
Secondary,
radiation.
it can cause a secondary malignancy, sir.
More question.
Management is available for this. Targeted therapy.
Yes, sir. Tyrosine.
Sorafenib.
Tyrosine.
Yes, sir.
What is that?
Tyrosine
kinase
kinase
inhibitors,
inhibitors. BRAF inhibitors.
So mainly for very rare case we are doing. Even what is the role of external beam radiotherapy?
Can complete
And anaplastic carcinoma.
Anaplastic.
palliative.
Suppose there is a metastasis in the medial end of clavicle.
We can
Solitary
metastasis we can excise.
Exercise. So always surgery is preferred over radioiodine, because radioiodine will take time for action.
6 months.
Surgery will give immediate.
Treatment.
So if resectable metastasis, always you do resection.
Resection.
If non-resectable, you go for
Ablation.
radioiodine, especially skull and all. That is how you treat the metastasis. And the visceral metastasis dose is 100 to 200. Other bony, etc.,
300.
200 to 300. That millicurie. That is the dosage.
I think we will come to a conclusion. Suppose by chance it become a cold abscess.
This
Okay.
lymph node, sir.
Yeah. How did you treat?
So we'll start on ATT. So if patient is responding, we'll continue the ATT. If not responding, we can do non-dependent
So he
drainage.
has a cold abscess, you will wait for how long? The response to the treatment which minimum takes
2 to 3 weeks.
So with the cold abscess you will allow, it will not rupture.
If it's not rupturing, we can wait. So otherwise, if it is too tense, we can do non-dependent drainage using zigzag technique.
What
We
is
should not
non-dependent drainage?
Anti-gravity, sir. We should not
Keep drain.
keep.
So how, will you start ATT?
Yes, sir.
Yes, sir.
So what is the ATT you start?
HRZD.
How much dose? What is the ATT dose?
Isoniazid sir 5 mg per kg and rifampicin.
So how it comes now?
Sir, it comes in a
FTC.
fixed dose combination. It is
Okay.
dependent on the weight, sir. As per
Weight.
weight, we'll give one. I
It is
will-
category 1, 2, 3.
2, 3. As per weight, sir, we'll.
No, what is this category?
Now there are only two
Two
categories.
category.
sir.
Very good.
One is new and second category is all other previously treated recurrent will give in the category 2, sir.
Suppose it to prove to be MDR positive
Category.
or it is resistant.
It's a category which we are going to keep or treatment, sir.
Treatment you are on to.
Treatment, sir, will not give rifampicin but will give a second line of ATT which can be levofloxacin or
Amikacin.
What are the newer drugs which is used?
Beraquilin.
Bedaquiline, sir, is a newer drug.
So how long you will give?
It is also given for the 18 months, sir.
Which that is also changed. That is what I asked you. Now the new regimen of bedaquiline has come only for a 6 months regimen. So it is from 18 months they brought to 9 months. Now most of the our government is yet to announce it, but it is most of the pulmonologists started using a 6. So tuberculosis is our national disease.
Yes.
So anywhere they can lead on to that, then they will be doing that. Okay.
The operative part and the medullary carcinoma part, that's we have not touched.
Yes, sir.
Can read it. Okay.
Good.
Thank you all.
It is ready?